We've all become vulnerable to the problem of compulsive overconsumption or addiction, which is a more severe form of overconsumption. Obesity rates, for the first time in human history, we have more people on the planet who are obese than are underweight.
Dr. Anna Lembke, psychiatrist and addiction specialist.
Our biological imperative evolved over millions of years of evolution, which is to seek out rewards, consume as much as possible as soon as we encounter them, and then once we've ravaged that particular resource, to go on to the next one.
How do you know, for example, if you or somebody else is addicted? What should you look for?
So what I recommend as a first step is withdrawal, finding that when we reduce or stop our consumption, we have an adverse physiologic, painful reaction to that, which is part of what motivates us to want to do it again and again. A degree of loss of agency, which is a really core part of addiction. The more addicted people are, the greater that loss of agency, to the point where I'll never forget a patient of mine who called me up and said, "I'm surrounded by empty vodka and wine and beer bottles, and I simply cannot stop drinking. Will you help me?" And I said,
Hey there, welcome to the Happy Habit Podcast. I'm Matthew. You'll find me here Mondays and Thursdays talking to experts in the fields of health, well-being and self-improvement. If you already know the podcast and enjoy the content, well, please show your support because an awful lot of work goes into these videos. Please like, subscribe, share with other people who you think might get value from these videos as well. You can also leave the podcast a positive rating on iTunes and on Spotify. And if you're on YouTube, become a subscriber over there too. We've had a 50% increase in subscriber numbers on YouTube in the last month alone, which is amazing. It's a vote of confidence. Join the conversation, leave a comment under any of the videos over there. You can also click that bell notification for any future videos which come every Monday and Thursday. Now today I'm speaking with renowned psychiatrist Dr. Anna Lembke. She is the author of the terrific best-selling book Dopamine Nation. We live in a world where we are addicted to being overstimulated, and we're addicted to overconsumption of everything from food to digital experiences, which is very much at odds with how our ancestors lived, given that we live in a time of abundance and they lived in times of scarcity. And the result is mental and physical health problems for us today. In this episode, we look at the chemical dopamine, which facilitates habit formation and ultimately addiction. We learn of the pleasure-pain balance and how we suffer when there is an imbalance, favouring either pleasure or indeed pain. Discover why embracing discomfort or some degree of pain is actually a good thing and why too much of a good thing is bad for us. And expect to learn the warning signs to look out for in yourself or in others that suggest addiction might be occurring. Plus, we hear of some of the steps we can take to mitigate against addictive behaviours. I really enjoyed this conversation with Dr. Anna Lembke. Indeed, I've waited 2 years to get to talk to her. She is full of information and advice, so this interview is definitely worth checking out. I hope you enjoy. Well, Dr. Anna Lembke, thank you so much for joining me on the podcast today. I really enjoyed your book, Dopamine Nation, and I'll stick a link to that in the show notes of this episode for people to check out. Human beings, you've said, are dying because of their habits and behaviours, but both of these things are modifiable. Can you explain?
sure, we are living in a time of unprecedented wealth, leisure, abundance, and what I call drugification of everyday life, meaning that traditional drugs have been made more accessible, more potent, more novel, more bountiful. And we have new drugs that didn't exist before, like video games and social media, and even behaviors and substances like exercise and food that we think of as healthy and central to survival have also become drugified in one way or another, such that we are now living in a time where we've all become vulnerable to the problem of compulsive overconsumption or addiction, which is a more severe form of overconsumption. And as a result, we're essentially titillating ourselves to death. If you look at, for example, obesity rates, for the first time in human history, we have more people on the planet who are obese than are underweight. The top 3 causes of death worldwide are due to modifiable risk factors, namely smoking, sedentary lifestyle, and our diet. So all of this kind of speaks to the ways in which the modern world is stressful and challenging in new and unprecedented ways that are directly related to our biological imperative evolved over millions of years of evolution, which is to seek out rewards, consume as much as possible as soon as we encounter them, and then once we've ravaged that particular resource, to go on to the next one, which is a great mechanism in a world of scarcity, but certainly a liability in the world that we live in now.
Well, this is it, and you emphasize that our ancestors lived in a time of scarcity. We live in the diametric opposition to that, because everything is at the touch of a button, or you don't even need to leave your house now if you want to order anything, be it goods or food. Even we now are talking via the internet, thousands of miles between us, but that convenience and that immediacy is something that our ancestors never had to deal with. But this presents us with an awful lot of problems, namely that addiction and addiction to dopamine.
Yes, exactly. And I'm glad you point out the upsides. There are so many good things about modernity and about the technology that's allowed us for more leisure time, for interconnectivity. Our telecommunications revolution has so many good things about it. But it is also very good that we're beginning to become aware of and talk about the dark underbelly or the negative consequences of this technology.
Can we talk then about dopamine? Can we define what it is, its mechanism of operation in the brain, and its role in terms of addiction?
Sure. So dopamine is a neurotransmitter. Neurotransmitters are the chemicals that bridge the gap between neurons. Neurons are the wires that make up our brain. They conduct electrical signals, but they don't actually touch end to end. There's a little gap between them called the synapse, and that gap is bridged by chemicals called neurotransmitters. Those chemicals allow for fine-tuned modulation of the electrical circuits. Dopamine is one of many human brain neurotransmitters, and it's now known to be essential for the experience of pleasure, reward, and motivation. In the reward circuit, which is a specific circuit in the brain, there are many neurons that are rich in dopamine release and dopamine receptors. The more dopamine that we release and the faster that we release it in response to behaviors we do and substances we ingest, the more likely we are to do that thing again. And also the more likely that thing is to be addictive or potentially addictive in vulnerable individuals. And again, I would argue on some level, with an ecosystem with enough drugs in it, we are all vulnerable. We're always releasing dopamine at a kind of baseline tonic level. And so what we're really measuring here is increases in dopamine firing above baseline or decreases in dopamine firing below baseline, and appreciating those increases and decreases is really fundamental to understanding how our brains change as we go from healthy adaptive consumption to unhealthy maladaptive and in some cases addictive consumption. I should emphasize that addiction is based as a diagnosis that we make based on phenomenology, meaning patterns of behavior over time characterized by continued compulsive use of the substance or behavior despite harm to self and or others. Although there are distinct brain changes that we know from human studies and animal studies that characterize addiction, we don't have any blood tests or brain scans to diagnose addiction. We base it on these patterns of behavior where consumptive tendencies become so out of control that the individual is harming themselves and or harming other people. We look for the 3 C's: control, compulsions, and continued use despite consequences, as well as physiologic markers of dependence like tolerance, needing more of a drug over time to get the same effect, or finding that at the same dose it simply stops working, and withdrawal, finding that when we reduce or stop our consumption, we have an adverse physiologic, painful reaction to that, which is part of what motivates us to want to do it again and again. Also important to point out. Oh, sorry, go ahead.
No, I was just going to ask you then, in that instance, is the term addiction then, which has entered the zeitgeist and entered the vernacular across the world, is it overused then by people who don't really understand exactly clinically what it means?
I think you could make that argument. It's very, it's not just a medical term. It's a very common lay phrase that people will use casually to describe their consumptive habits, even when they don't really think that they're dealing with a serious, disorder. When I use the term addiction, I use it very specifically to denote a form of psychopathology, and not in a kind of lay casual way. Although in my personal life, I have been known to say things like, I'm addicted to romance novels. Now, as it happens, I really think I was a little bit addicted to romance novels, as I write about in my book. But at the time I was joking about it, the joking manner in which I used that phrase was also a form of denial or deflection, my not wanting to really look closely at the behaviors, so joking that I was addicted. But yes, it's a good point. We're straining here with the language. The language is also in flux. And so different people will use addiction in different ways. But generally, when I use that term, I'm talking about the more severe forms of psychopathology. When I talk about compulsive overconsumption, I'm talking about like usually a pre-addicted state.
So just to dig down then again, I'm sorry to be pedantic about this, but for people who are listening and who are watching this, what red flags should people be looking out for in themselves or indeed loved ones as far as the characteristics of addiction are concerned? How do you know, for example, if you or somebody else is addicted? What should you look for?
Yeah, so we use the Diagnostic and Statistical Manual of Mental Disorders, which lists 11 criteria. These are criteria that were developed through expert consensus, individuals who have a lot of experience treating patients with addiction, coming together and characterizing the phenomenology, creating these criteria, and then identifying it as a spectrum disorder. The more criteria you meet, the more addicted you are on a scale from mild to moderate to severe. The 11 criteria are frankly difficult to remember and spontaneously regenerate, which is why I often teach the three, or if you will, the 4 C's: control, compulsion, craving. So I added cravings and consequences. So control means repeatedly planning to cut back and not doing it, or planning to use in moderation and finding that we're habitually going over those moderated amounts. Compulsion means a lot of mental real estate occupied with thinking about the drug, using the drug, maybe hiding the drug use, as well as a certain level of automaticity. Again, maybe I planned not to use in a given time period, and then I almost unconsciously experience myself ingesting that drug. Again, I use drugs loosely to encompass both substances and behaviors and food, ultra-processed food, which speaks to a degree of loss of agency, which is a really core part of addiction. The more addicted people are, the greater that loss of agency, to the point where I'll never forget a patient of mine who called me up and said, I'm surrounded by empty vodka and wine and beer bottles, and I simply cannot stop drinking. Will you help me? And I said, go to the emergency room and tell them that you're suicidal. And she said, but I'm not suicidal. I want to live. I just can't stop drinking, which also characterizes some of the significant limitations in our healthcare system. If you go to an emergency room, at least in the United States, and you say you're suicidal, generally that will be taken very seriously and you'll get admitted, and there are treatment algorithms. If you go and say, I can't stop drinking, people are sort of like, don't know what to do with that, which is absurd. But those are distinct things, suicidality and, using substances to the point of potential death, because most people who are addicted actually do not want to die. So anyway, just a small aside there. So that's compulsions. Cravings are intense, intrusive thoughts or feelings of wanting to use that can come unbidden and out of the blue. And then the sine qua non of addiction, again, is this continued use despite consequences. Sometimes those are consequences that people can see. It's that kind of Aristotle's wide-eyed incontinence. Why do I do the things that I don't want to do? But sometimes people are in denial. Denial is very common in addiction. They minimize the harms. They maximize the benefits. Even though everybody around them says you have a problem, they say, no, I don't have a problem. There's a kind of a joke in the addiction medicine field that denial is not just a river in Egypt, or denial is an acronym for don't even know I am lying, which is it's really true. People can get this kind of interesting split brain phenomenon where they're leading this kind of double life. Over here, they're addicted, and over here, they're in denial. And really, the two are in their consciousness quite far apart. And then, of course, again, the tolerance and withdrawal. A soft sign of addiction is if people are lying about their use. That tends to be a harbinger, even if it's like subtle lies about degree, like, oh, I just had a couple of drinks with friends, when in fact it was much more than a couple drinks, right? Oh, or I just spent $50 at Nordstrom's, when in fact it was $500, right? So these kinds of slightly changing quantity and frequency as a way to minimize in their own mind and minimize to other people, and then kind of overall be able to stay in this sort of hazy space of denial where my narration of what I'm doing then becomes the version that I believe. So those are signs and symptoms to look for.
Now, fascinating to hear that in detail. I'm just curious, as you mentioned denial there, how is it possible for, again, somebody who's a loved one to intervene in the case where somebody is in denial?
Yeah, so what I recommend as a first step is to engage the loved one in conversation at a time when we ourselves are not dysregulated, emotionally dysregulated, and preferably when they're not intoxicated and or emotionally dysregulated themselves. Sit down and really, come from a place of love, and also essentially try to be a mirror for them. Because as I just said, when people are in their addiction, they can't see true cause and effect, and they don't see themselves objectively. So to be able to reflect back to them, number one, I love you and I care about you, and this is why I want to talk about this with you, and here's what I see. And then stop. Stop. You could add on there, here's what I see, and here's why I'm distressed about it. I'm worried you're going to die an overdose. I'm worried you're going to get a DUI or hurt yourself or somebody else while you're driving. I'm worried that you are becoming estranged from our children. I'm worried you're going to lose your job, whatever it is. And then just sort of stop and let them have the room to respond or not respond. And, however they respond, don't spend too much time trying to talk them into or out of. Just sort of express your love, express what you see, express, your emotional concern. And, then potentially, if they seem receptive, offer to help them get help. And that's essentially what I recommend.
Terrific. A really informative answer to that question, a crucial answer, quite frankly. I'm glad I asked it now. You introduce a really good concept in the book, which I liked, that of the pleasure-pain balance, or seesaw. Pleasure on one side, pain on the other. Can you explain the idea behind this balance, or indeed imbalance, as is often the case?
Yeah, so the balance tries to capture one of the fundamental truisms of how our brains change as we become addicted, and that is the concept of homeostasis, which is essentially whatever our baseline neurochemical soup is, so to speak. Neuroscience has revealed that pleasure and pain are co-located in the brain, and at a very simple level, they work like opposite sides of a balance. When we feel pleasure, the balance tips one way, dopamine is released in the reward pathway. When we feel pain, it tips another set of chemicals is released. Certain rules govern this balance. The first and most important is that the balance wants to remain level, or what neuroscientists call homeostasis, such that with any deviation from neutrality, our brains will work hard to restore a level balance. How do our brains do that? First, by tilting an equal and opposite amount to whatever the initial stimulus is. So if I do something that's pleasurable for me, that releases dopamine. My balance tilts to the side of pleasure. If it's very, very pleasurable for me, as in intoxicating, that releases more dopamine, and my pleasure balance tilts harder to the side of pleasure. But no sooner has that happened than my brain will adapt or neuroadapt to that increased dopamine firing by downregulating dopamine transmission, not just to baseline levels, but below baseline. I like to imagine that as these neuroadaptation gremlins hopping on the pain side of my balance to bring it level again. But they like it on the balance, so they don't get off as soon as it's level. They stay on until I'm tilted the equal and opposite amount to the side of pain. That's the come down, the after effect, the hangover, what have you. Now, if I wait long enough, without using my drug of choice again, the gremlins hop off and homeostasis is restored, craving ends, and I go on my way. But rule number 2 of the balance is that if I continue to consume my drug of choice or another drug over days to weeks to months to years, I say another drug because all reinforcing substances and behaviors work on the same common pathway and ultimately release dopamine. So if I continue to either use the same drug or a whole bunch of different drugs, bottom line, continue to stimulate my reward pathway, those gremlins start to multiply, they get bigger and stronger, and eventually they're camped out on the pain side of the balance. And now I've changed my pleasure or hedonic set point. Right now I need more of my drug in greater quantities and more potent forms, not to tilt my balance to the side of pleasure and feel good, but actually just to get it out of the pain position and return to homeostasis and feel normal. This is what George Koob has called dysphoria-driven relapse. It's why people with severe addictions will continue to use their drug of choice even after they have zero pleasure in using anymore. They're just now trying to feel normal. It's also why people with addiction will often initially present in clinic seeking help with depression, anxiety, insomnia, inattention, and general despair. It's because they've, again, reset their hedonic set point. Other things that used to be pleasurable for them are no longer pleasurable because they can't compete with all the gremlins on the pain side of the balance. And their focus has really narrowed to this one drug, which they need more and more of in greater quantities to get any kind of response at all. So we get a lot of this sort of self-medication phenomenon where people think they're using their drug of choice to treat a depression, but really it's the use itself that has created the depressive symptoms, which is why an initial intervention is to have people abstain from their drug of choice for long enough for those neuroadaptation gremlins to hop off the pain side of the balance so that homeostasis can be restored. And what we find in the majority of folks who present with addiction or who present with depression, anxiety, but are engaging in addictive use of highly reinforcing substances is that if they can abstain for 4 weeks, the majority of them will feel better, even without our doing any other intervention for depression and anxiety. Now, we always emphasize that they'll feel worse before they feel better. You can imagine if you've got a balance and you take away the weight on the pleasure side, all those gremlins that have been accumulating on the pain side are going to smash us down to the side of pain. That's acute withdrawal. The universal symptoms of withdrawal from any addictive substance are anxiety, irritability, insomnia, depression, and craving. But if we can just ride out those first 10 to 14 days, those gremlins will, eventually realize, wait a minute, we're supposed to get off the balance. They'll hop off, assuming there's enough brain plasticity left to do that. Homeostasis will be restored and people will get relief from those symptoms, again, simply by avoiding their intoxicant of choice. Caveats to that are things like you wouldn't recommend that for somebody who is at risk for life-threatening alcohol withdrawal or life-threatening benzodiazepine withdrawal. You wouldn't recommend that for somebody who had repeatedly tried to stop on their own and was just simply unable to. You would recommend medically monitored detox, higher levels of care, a restricted environment, or as Amy Winehouse has said, rehab. Those are the kinds of higher level interventions. But as a first pass intervention, either with ourselves in our own lives or in an outpatient ambulatory clinical setting, that 4 weeks of abstinence can be a really nice litmus test for, number one, whether the patient is able to do it. I will often say to patients, hey, if you're not able to, even when you committed to, that tells us something about your agency or your volitionality here. And then really, to me, one of the most interesting things over 2 decades of work here is that how many patients will come back after those 4 weeks, having been successful in abstaining, and endorse significant reductions in depression, anxiety, insomnia, dysphoria, you name it. It just has been really revelatory to me when we see the ways in which our continued consumption of these highly reinforcing escapist drugs and experiences actually cumulatively over time makes us unhappy.
That's extraordinary that you see the powerful implications of abstinence. And I'm reminded of where you mentioned the 1920s in American prohibition and the positive effect that had on people who at the time would have been regular drinkers.
Yeah, so that was a decade from between about 1920 and 1930 when, through the temperance movement, alcohol was outlawed in the United States. And today, people mainly remember that as a failed experiment, which led to a black market for alcohol and increased crime. And although that is also true, what people seldom appreciate is that that period in which we had decreased access to alcohol, not zero, but markedly decreased because it was made illegal, was accompanied by a 50% decrease in public drunkenness, a 50% decrease in alcohol-related liver disease. And generally, those are markers of alcohol addiction. And even after alcohol was made legal again in the 1930s, that decade of abstinence continued to manifest in lower rates of alcohol-related harm for many decades until about the 1990s, when all of a sudden we began to have much more access, not just to sort of standard alcoholic beverages, but much more potent alcoholic beverages, which is where we are today. Now we're seeing, demographic groups like women and older people who were previously relatively immune to alcohol addiction now presenting, with women to men, 1-to-1 among millennials in terms of the risk of becoming an alcoholic. So, access is a huge risk factor. And, as I've said, we're now living in a world of almost universal access.
Well, that's it. We have access to everything now at the flick of a switch and the click of a button. We are overstimulated, and we don't live easily, however, with distraction or with discomfort or pain, to go back to that pleasure-pain balance. So could you talk to us about this and how we can use that knowledge to our benefit once we realize that we are not comfortable being uncomfortable?
Yeah, so I think, again, we always talk about sort of mindfulness as an important way to observe thoughts and feelings without judgment. One of the best ways to develop our mindfulness skills is actually to give up our drug of choice, whether it's romance novels or chocolate or cannabis or alcohol or video games, pornography, you name it. And to do that for long enough to reset reward pathways, knowing that initially it will be very difficult and then we'll be having to sit with a lot of discomfort as, again, we experience our brains trying to get us to use again, which our brains will do by saying, I'm anxious, I'm irritable, I'm restless, I'm depressed, use. But again, if we can just get through that initial period, many of us come out the other side with reset reward pathways, and much more innate joy in our lives. Paradoxically, the other thing that we can do is intentionally seek out things that are difficult, challenging, and yes, even physically painful, as long as it's not something like self-cutting, which doesn't work over the long run. But things like exercise, which is immediately toxic to cells, can actually lead to resetting reward pathways to the side of pleasure. So when we intentionally press on the pain side, not too much and not too little, those gremlins will jump over on the pleasure side and stay on until we're tilted to the side of pleasure. And we will get our dopamine indirectly by paying for it up front. What happens is that when we do things that are challenging, difficult, painful, our body senses injury, and in response to injury, upregulates feel-good neurotransmitters like dopamine, serotonin, norepinephrine, or endogenous opioids, or endogenous cannabinoids, etc. So that can be a really nice way to help reset our reward pathways. So instead of just abstaining, we can abstain and actually turn and face our pain and then take action to do difficult things. And we have loads of data showing that people who are trying to withdraw from drugs and alcohol, who engage in vigorous exercise, have fewer withdrawal symptoms, are less likely to relapse. We have data showing that if you immerse yourself in exercise or in ice cold water bath, for example, that dopamine levels will actually increase 300 to 400% over the latter half of that activity and then remain elevated for hours afterwards before going back to baseline levels of tonic dopamine firing without ever going into that dopamine deficit state, which is really nice because that dopamine deficit state is the state of craving that drives compulsive overuse. We do occasionally get people who get addicted to exercise. And of course, we've drugified exercise with all the machines and the measurements and the social media and the leaderboards. So now, like, even exercise can be addictive. But exercise in its pristine form without all of those accoutrements is generally not addictive. And we generally have to work and force ourselves to do it. We tend to have a very vivid memory of the initial stimulus, whether it's pleasure or pain. We have a very poor memory for the gremlins, which is why people with addiction will often have euphoric recall of what their drug used to do for them and not very good memory for all of the harms that come, including the fact that it doesn't work anymore. It's really fascinating how we can't recapture that. But on the other side, too, every time I wake up in the morning and I know I should get out of bed and I'll feel better if I walk or swim or what have you, it's still every morning it's a challenge to do that, even though I know cognitively I'll feel better afterwards. Viscerally, all I can think is I just want to stay in bed. So our brain has a funny sort of disconnect there. And probably we evolved to have that because we evolved for a world of scarcity in which if we were not constantly seeking out the next reward, we were going to die. So this is sort of this mismatch problem that we're facing now.
You mentioned another form of abstinence, and that is delaying gratification. Now, this is really interesting because instant gratification has a negative effect on the default mode network in the brain. Can you explain this?
Well, I mean, again, what we're looking at is essentially dopamine fluctuations. And when we ingest an intoxicant, we have a sudden spike in dopamine, which is really not what we were evolved for. We were evolved for a world in which we would have to work very hard to get a tiny little spike in dopamine. So our brains are, in essence, reeling in response to this sudden flooding of dopamine and then downregulating dopamine to this kind of chronic dopamine deficit state. And that's essentially, the addicted brain. So we're kind of messing with our balance.
It's incredible, really, and it's incredible just listening to you talk so passionately about this subject, and you clearly have a vast amount of experience in this area. Just one final point. I'm mindful that there may be people, again, listening or watching this who are addicted themselves or who have loved ones, family, friends who are addicted. Could you just give us a piece of advice as far as options being open to them is concerned? Because people tend to have a very closed mind as far as what options are available to them if they feel trapped and addicted to something. So could you speak on this?
Yeah. So, I mean, there are so many options, right? You can go see an addiction psychiatrist or another type of addiction mental health provider. You can go to a mutual help group. These are 12-step meetings based on Alcoholics Anonymous that have proliferated all over the world, that are available for almost every type of compulsive overconsumptive behavior known to humankind, and that are evidence-based. So we have good evidence now that people who actively participate in 12-step groups, go to meetings, do the steps, get a sponsor, work the steps, have outcomes that are as good as people who go and seek out professionally mediated treatment. And the longer you go out, the better the outcomes for 12-step groups. So those are, and 12-step groups are everywhere and they're free. And the only requirement for attendance is the desire to stop using our drug of choice. So whether you go to a medical professional or whether you go seek out a peer support like the 12-step groups, there are lots of resources out there. If all of that even seems too overwhelming, tell a loved one, tell a friend, reach out for a helping hand, let somebody know. Don't stay isolated. Addiction is the great isolator, and recovery is about reconnecting with people.
Beautifully put. The book again is called Dopamine Nation. I will stick a link in the show notes for this episode if people want to seek that out themselves. But Dr. Anna Lembke, absolute joy, worth the wait to talk to you today. Thank you so much.
Oh, you're welcome. Thanks for having me.
Well, thank you for tuning into this episode of the Happy Habit podcast. If you liked it or any of the previous 400 plus episodes, like, subscribe, share with others who you think might enjoy them too. leave the podcast a positive rating on iTunes or on Spotify. And if you're on YouTube, join all of the other new subscribers. There's been a 50% increase in the last month alone. You can become a subscriber there. Leave a comment under any of the videos and click that bell notification for any future videos which come every Monday and Thursday. Until next time, stay happy.